Poster number 1 is the importance of pouch size in laparoscopic Roux-En gastric bypass, a prospective cohort study being presented by David Edholm from Sweden.
And I just want to remind, I'm Edholm. I just want to remind everybody that we have online questions. So if you have questions as things are going on and maybe you're too shy to come to the mic, please submit them. We have a small group, so I think we can make it really interactive.
All right, good afternoon. I'd like to start by thanking SAGES for the opportunity to present. So this is a cohort study from Uppsala University, Sweden. It's a nationwide study. I have nothing to disclose. So the importance of pouch size in gastric bypass has been under a lot of debate. It's been stressed that a small pouch gives better excess weight loss. Now, we used, as a proxy for pouch size, we used the length of stapler needed to complete the pouch in this study. And we tried to see how that affected outcome with regard to marginal ulcers and excess BMI loss. So we had 14,000 patients with complete 6-week and 1-year follow-up. 76% were female, 41 years was the mean age and the mean BMI of 42. 0.4% required conversion to open surgery, and a mean 145 millimeters of stapler was used to complete the pouch. So that means that after the first horizontal stapler, you have basically 2 staplers to complete the pouch. The mean BMI at 1 year was 30. And the marginal ulcer rate was 0.9%. That's likely an underestimation since we know that a lot of them are asymptomatic. Okay. So we found that female gender, a low preoperative BMI, young age and absence of diabetes predicted a better excess BMI loss at 1 year. Length of stapler was negatively correlated to excess BMI loss at 6 weeks. That means that if you used a lot of staplers, you had a worse, you lost less weight, but it didn't affect excess BMI loss at 1 year. We also found that the relative risk of developing a marginal ulcer, that actually increased by 14% for each centimeter of stapler that was used to complete the pouch. So the bigger the pouch, the bigger the risk of getting a marginal ulcer. All right, thank you for listening.
John Lynn, Chicago. I really liked your study. 2 questions. How did you evaluate patients for a marginal ulcer? Did they all have post-op endoscopy? And the second question, did you use medications or other ways, H. pylori testing, anything like that, to help prevent against ulcer formation?
Okay, so only the patients with endoscopically verified ulcers were registered. So we think that a lot of them are asymptomatic and thus not registered. PPI is used by approximately half of the patients prophylactically, but then at 1 year they shouldn't be taking prophylactic PPI. That's a good question, though.
Thank you, Dr.
Thank you very much.
Thank you.
Our second presenter is poster number 2, Simulap and Laparoscopic Common Bile Duct Exploration Simulator, being presented by Dr. Sergio Rojas Ortega.
Thank you. Thank you for the opportunity, and thanks, SAGES. This poster is Simulap and Laparoscopic Common Bile Duct Exploration Simulator. It was done by Emina Pasic, Rachid Cecin, Gerardo Reed, and by myself. Many surgeons are not comfortable in treating common bile duct stones during laparoscopic cholecystectomy. However, I have nothing to disclose. However, if the diagnosis is established during the interpretive cholangiography, the surgeon is confronted with a therapeutic dilemma, that is the choice among laparoscopic common bile duct exploration, conversion to open surgery, or postoperative sphincterotomy. In order to show how easy it can be to perform a laparoscopic common bile duct exploration, we presented a video to 10 general surgeons. Then we invited them to the laboratory where we test the Simulap for common bile duct exploration with a flexible cholecystoscope. Each surgeon performed transcystic and choledocotomy technique. Only 10% of the group had experience with the flexible cholecystoscope, and the instruments needed to perform laparoscopic common bile duct exploration. We taught the technique in the simulator and then measured the time for each participant. The time to perform the laparoscopic common bile duct in the simulator was 15 plus minus 5 minutes for the transistor technique and 25 plus minus 8 minutes for the cholecystectomy technique. Each participant achieved success in completion of the laparoscopic common bile duct for 100% stone extraction. We asked each surgeon what will be the impact of their clinical practice after they completed the simulation, and was 50% in favor of laparoscopic common bile duct as a treatment for common bile duct stones. Our conclusions are that simulators can impact positively on the surgeon practice once they know how to perform the technique. Obviously, this is the first step on our clinical path to practice, but as many techniques, the daily practice in simulators can shorten the learning curve in the laparoscopic common bile duct exploration. Thank you very much.
Hi, Juan Pablo Pantoja from Mexico, but it's a very ingenious simulator. Do you come up with like a curriculum for training in laparoscopic stone extractions for your surgeons, or just told them your technique and I mean, it sounds like you need to do a couple of exercises before and teaching suturing and teaching some other probably technical skills before the extraction itself. Do you come up with something to train them?
Well, I just showed them the video, and the objective was to convince them about how easy it can be to perform the technique, because most of the surgeons, like I heard in a previous talk, only 7% of the surgeons have to know how to do this technique. So I think this is the way to do it.
I think it's a complete different way of doing just a lap collie versus doing a formal laparoscopic bile duct exploration. You need more ability. So do you know if there is something there, like a curriculum for training that part?
Well, I'm not sure, but I think the first thing that you have to do is the simulator, and then you have to practice with animals and all those things.
What he's asking is, did you make the curriculum for this workshop up yourself, or was it materials that you found elsewhere that you used? Did you build the course yourself?
I did it by myself.
Very good. Okay. Are those available to others, or is that something
Not
you
yet.
keep close?
Maybe next.
Okay.
Coming soon.
Wonderful. We'd love to see it.
Love to see that.
Thank you.
Absolutely.